My name is Shah. I'm a radiation oncologist at the Cleveland Clinic. I serve as the Director of Breast Radiation Oncology, as well as the Director of Clinical Research in Radiation Oncology. The role of adjuvant radiation in patients with 1 to 3 lymph nodes continues to evolve. For decades, adjuvant radiation in this population following mastectomy and axillary dissection was given based on inclusion in randomized trials. However, recent data has allowed us to further clarify that position. In women undergoing lumpectomy found to have 1 to 3 lymph nodes involved, the most important fulcrum is deciding whether or not the patient had axillary dissection. If the patient had 1 to 3 lymph nodes involved and only had a sentinel lymph node, then adjuvant radiation is an absolute and should include both the breast and the regional lymph nodes. If the patient underwent axillary dissection, multiple options are available. The MA20 trial, published in the New England Journal of Medicine, included 85% of patients with 1 to 3 lymph nodes involved, with all patients undergoing lymph node dissection. The trial randomized women to the addition of regional nodal radiation or not, and with long-term outcomes found a reduction in local regional recurrence, distant metastases-free survival with the addition of regional nodal radiation, as well as a survival advantage in estrogen receptor negative patients. This data can be used to recommend adjuvant radiation in patients with 1 to 3 lymph nodes involved following axillary dissection. However, some clinicians may wish to limit radiation in patients who have otherwise favorable characteristics, including estrogen positive disease and older patients with low nodal ratios of involvement. With respect to patients undergoing mastectomy, the first decision point is also whether or not sentinel lymph node or axillary lymph node dissection was performed. If 1 to 3 lymph nodes were involved and sentinel lymph node was performed, adjuvant radiation therapy to the chest wall and regional nodal basins remains standard. In patients who have 1 to 3 lymph nodes following axillary lymph node dissection, this remains a controversial topic. Previous studies, including randomized trials as well as meta-analyses, have demonstrated a benefit to adjuvant radiation in these populations, though these findings are limited by older surgical techniques, systemic therapies. More recently, extrapolation from the previously noted MA20 trial has occurred, allowing for support of patients receiving radiation therapy with 1 to 3 lymph nodes involved following axillary lymph node dissection. However, clinical discussion and informed decision-making with the patient is paramount in these cases, and low-risk patients, including older patients with estrogen-positive disease, no LVSI, and limited nodal ratios, may favor the omission of radiation in that population.